Alrighty, welcome to Decoding DX, everyone. Thanks for joining us, whether you're here live or watching on YouTube. Glad you could join us. We have a really fun case tonight of altered mental status. So our guest discussants tonight, our third-year student is Heather Minchew. Her and I go back quite a bit. She's super awesome. So Heather, why don't you introduce yourself? Tell us something fun about you that doesn't involve medicine. You're muted.
Sorry. I'm Heather. I'm a third year here at KU. Something fun about me that isn't medicine related. I have 2 dogs that are like the love of my life. And I also have adopted a lot of plant babies over quarantine. So my poor husband, every day he comes home, just gets pissed at me because I've propagated a new plant. But it's been a fun hobby.
Love it. That's awesome. And then our more expert discussant today is Dr. John Fritzlen. He's a third-year internal medicine resident and soon to be chief next year. So we're super glad that he's donating his time to us. So if I'm not mistaken, I think he wants to be called John.
Yes, please don't call me Dr. Fritzlen. John, please.
Perfect. What's something about yourself that doesn't involve medicine?
Oh gosh, I have 2 young kids, 2.5, and then soon to be 1. So they take up like all of my time outside of medicine. They're great. Jack and Caroline, they're a lot of fun. And then have a dog too. So it's a busy household over here. Not a lot of sleep, but it's a lot of fun. So I enjoy being a dad.
Sounds like a lot of fun. That's awesome. All right, just a few little announcements before we get started here. First, quick disclaimer, none of this is to be used for medical advice. The only real doctor on this call is John. So even that, none of our opinions are meant to reflect KU or anything like that, and nothing is to be taken for medical advice, just education. I also wanted to plug signing up to be a student member of the ACP. It's a super awesome resource. They have tons of free resources for you. It's totally free. And then you can get access to all the meetings and all that kind of stuff. So I will put the link to that in the video description and in the show notes to sign up for that. And then lastly, if you are enjoying these videos, if you're enjoying what we're doing, we do have a few expenses, including the Zoom account. So if you go to our website, decodingdx.com, we have our Venmo. We'd super appreciate even just like $1 support just to help out with those costs. But regardless, we're glad everyone's here, glad we're watching. And we will go ahead and get started with the case if Kelsey's ready. Super. Kelsey's our wonderful scribe tonight. So our chief complaint is altered mental status. And I'll start with the first aliquot with kind of just the HPI and going through the exam. But before we get to that, real quick, Heather, what goes through your head when you hear altered mental status?
So I kind of think like broadly, so like stroke, or like drugs. You think about like, was this patient in a car accident? Is it acute onset? Has it been happening for months?
Yeah, that's a great start. That's an awesome start. Definitely having a bit more information of even just where is this patient at? Are we in the emergency room? Are we in a clinic? What's going on? John, what else do you have to add what goes through your head when you hear altered mental status?
Yeah, it's such a tough one with altered mental status because it is a term that, let's say, the ER maybe uses when we really don't know what's going on. It can mean just about anything. It really can. It encompasses every single kind of organ system, so many different pathologies. So when I think altered mental status, I think could be really anything, and you just don't know until you start getting into the history, start getting into medication, start getting into labs. So yeah, really could mean anything.
For sure. Like most things, if you're in the ER, go through your ABCs. Is your patient stable? If your patient is stable, then you can move on to getting more information. So on that note, more information. We have a 66-year-old male today presenting in the emergency department. He was brought here from his skilled nursing facility for altered mental status. So a bit more information. About 12 days prior to this, he had been discharged from a different hospital after about a 10-day admission for the same complaint, the same kind of altered mental status, not quite sure what's going on. At that time, they had found his calcium level to be 11.4, so just kind of mildly elevated. He was treated with some IV fluids, and they had decided that they thought that his hypercalcemia was just kind of relative from being dehydrated, so they gave him some IV fluids, found an asymptomatic bacteriuria, gave him some antibiotics for that, and then sent him back to his skilled nursing facility. But then this kind of altered mental status came back, so they brought him to KU this time. On review systems, he has had a weight loss of about 40 to 60 pounds over the past kind of 3 to 4 months, but he's also been having a lot lower oral intake during that time. Significant comorbidities include HFrEF, so heart failure with reduced ejection fraction, coronary artery disease, hypertension, hyperlipidemia. He's had 2 prior strokes in the past, which have rendered him immobile. So he's got residual weakness, and so he requires assistance for all of his ADLs and is bedbound. So significant meds that he's on include carvedilol, furosemide, atorvastatin, aspirin, and clopidogrel. So kind of your run-of-the-mill standard heart disease type medications. As far as social history, that type of a thing, he lives in a long-term care facility due to his residual stroke deficits. No particular tobacco use or alcohol use or anything like that. So I'll let Kelsey catch up for just a minute. And then moving on, and Kelsey, I can supplement some of this extra info later too. Moving on to the exam, his vitals are overall unremarkable. He's afebrile, his heart rate is 64, his blood pressure is 109/62, his respiratory rate is 14, and he's satting 98% on room air. On exam, he's alert and oriented ×3, but he's just a little lethargic and kind of slow to respond. He does respond with sensical answers. It just kind of takes him a minute to think about it. HEENT was normal limits. Cardiovascular and pulm were both within normal limits. Abdominal exam was within normal limits. Neuro exam was consistent with prior documented weakness and deficits from his previous strokes, and otherwise was unremarkable with no other deficits. And on extremity and skin exam, he had bilateral atrophy in his legs, which was consistent with known immobile status, otherwise was unremarkable. So Heather, given this extra information with kind of the extra HPI, maybe starting with kind of that background knowledge and then adding on the foreground knowledge of kind of this exam, has that kind of narrowed down what you're thinking about?
Yeah, so I think we can potentially eliminate like drugs being, side effects of drugs causing something. When you first said 66-year-old male, and then it was like previous UTI, I'm like, oh, is this another UTI kind of thing that's going back again? I'm trying to think what else. And then the previous history of a stroke just makes you like, that keeps coming back. I wonder what his baseline is in terms of mental status. Is he always kind of slow to respond, kind of having residual issues with that? The weight loss is interesting. He's been eating less. Is he forgetting to eat? Is he vomiting? What's going on with that?
Yeah, so I can answer that just quickly. He really just hasn't had a whole lot of an appetite. He just kind of stays in bed all day and doesn't, he's got some depression and just due to his poor functional status, just really doesn't eat a whole lot. So, yeah, I know, it's kind of a sad case. But John, so given that, any extra like insights, any things that are ringing any bells in your head?
Sure. So when approaching a patient like this, I kind of go through different systems that it could be. I think neuro, he's got a history of strokes. Has he had a repeat stroke, or sometimes we see not a new stroke, but what we call a recrudescence, or just manifestation of some of their prior deficits due to relative hypotension. Maybe they have poor perfusion. His blood pressure is a little on the softer side, so maybe that's playing a role. Think of, is there any others, like, seizures or any history of that? Doesn't sound like it. So I kind of go through neuro, and he's certainly got things at risk. It doesn't look like he's on any centrally acting medications that could be contributing. So when thinking neuro, certainly at risk for more strokes. When thinking of kind of other infectious potential etiologies, he has history of UTI. Certainly would warrant getting a UA to evaluate that. It's always tricky when people come in from skilled nursing facilities, because a lot of times there isn't family readily available, and especially during the COVID time when visitor policies are restricted. It's tough to get additional information. So a lot of times you have to call the facility, try to get what their baseline was, and was he at the facility before his first hospitalization? Trying to talk with somebody who's seen him more recently and can kind of describe the changes that we're seeing. So certainly infectious. You always think of metabolic etiologies. It's interesting that you bring up the calcium of 11.4. You mentioned some dehydration. Sometimes hypercalcemia can cause dehydration itself, and may not just be dehydration causing hypercalcemia. That combined with the weight loss, I always think of, potentially, malignancy in the setting of, weight loss and hypercalcemia. Typically, if you start seeing calciums above like 12 or 14, I just saw somebody with a calcium above 16. Those are, when they get that high, it's mostly associated with malignancy, but even something like 11.4, I'd want to know, as he had prior, cancer screenings, things like that. Would just kind of dig into his history a little bit more. Less concerned about some sort of cardiovascular or pulmonary process causing some of his altered mental status. It doesn't sound like he's got any history of liver disease or cirrhosis or anything like that, but always have to think about those sorts of contributors. So I think at the top of my list is some sort of recurrent cerebral vascular injury, some sort of metabolic process like hypercalcemia can cause the moans, groans, bones, psychiatric overtones, as well as infectious etiology with potentially urinary or some other source.
I love that approach. Just to kind of step back, I noticed you kind of creating categories of how you're thinking about this. So you mentioned a variety of different, like you said, infectious causes. Is this more neuro injury? I know the clinical problem solvers have an awesome kind of framework that they used to think about altered mental status, that they say MIST: metabolic, infection, structural, and toxin. So that kind of lists out 4 big buckets to kind of just help guide our differential. My husband happens to be a pediatric neurology resident, and he said that we should, his opinion is to modify that to MINTS, to include neurologic as its own category. So metabolic, infection, neurologic, toxin, and structural. He's of the opinion that neuro deserves its own category. He's biased, but yeah, I love the approach of having kind of a structured way that we approach a chief complaint, no matter the situation. I think is really helpful to make sure that we're not missing any category. We can then kind of siphon down depending on what patient we have in front of us. But the other thing that I heard you say that I think is gold is just needing to get in contact with someone who's been around him recently. Oftentimes, in med school, we're taught about, old carts and go through all your HPI, but if your patient isn't able to respond to you, that is not going to help you. So just, not being afraid to get on that phone and to call, whether it's family members or members of the facility or anyone who's able to give you some extra information. Information is definitely power in a situation like this. So I love that from both of you. Great insights. So with that, what would you be looking for first? Real quick, from both of you, what would be kind of your, your top 2 or 3 things that you want to order, or where your eyes will be going immediately as soon as you get results back? Heather, we'll start with you.
Yeah, so I always think what's going to kill him first, which would potentially be a stroke. So I'm not sure of the exact how you initiate that protocol, but do that.
Yeah, so trigger the code stroke. In reality, if you are in the emergency department, that's going to be done before you even see the patient. They will call that based on triage or based on the EMS report. And that patient will be in the CT scanner likely before you even get to talk to them. But if you're on the floor and this is a new thing, definitely calling a colleague, calling a nurse, seeing if they can help you out, especially if your patient is decompensating, and then calling a code stroke, definitely. John, what about you? What are your eyes going to first when you start getting results back?
Yeah, so certainly the CT head, I think we know it's going to be abnormal, based on prior strokes. And CT head it's more of a screening to see if there's any gross abnormalities, looking for any sort of, doesn't sound like he's, it sounds like he's bedbound, so it doesn't sound like he's had like a fall or hit his head or hasn't been any trauma, but always make sure that there's no neurosurgical emergency, there's no bleeds going on, no midline shifts, nothing like that, once you see, that's out of internal medicine's hands. That's, you need to get the right consultants on. So certainly CT head, but a lot of the times it really isn't helpful. A lot of times you don't see anything to, explain the symptoms. So it's good to rule out the big things with the CT head. And then I go to just the basic labs, metabolic panel. I think definitely giving his hypercalcemia to see kind of where that's at. It gives me an idea of, his electrolytes and kidney function, sodium. I mean, he may be really dehydrated. He hasn't been eating or drinking much. Dehydration can cause altered mental status. So I can get a lot from just a basic metabolic panel. And then with his history of UTI, is certainly going to be looking at the UA to see if that's contributing.
Awesome. And I wonder if you can give us a little insight. If we're on the floor and we have concern for a stroke, how do we actually call a code stroke?
Sure. I think I haven't had to call code stroke myself. I've had to have the nurses call it. So, but it should be just the 85656. I think that's like the code blue line. It gets you your different responses, if it's a code blue or if it's a stroke response, or ACS for acute coronary syndrome, or a lot of our different responses that KUs have that should be within the same kind of, I think, phone line. And then that gets you the neuro nurses. They come by, they do the NIH. You get to one of the neurology residents there as well to do their assessments and kind of hear the story, and then discern kind of what's the next best steps from there. So I've definitely had nurses call code strokes for me.
Love it. One of the practical things that we don't actually learn in med school.
Yeah.
All right. So with that being said, we'll get you some labs, and I'm going to kind of distill this down and only really focus on the pertinent findings in the labs. So first, I'm going to list labs that were within normal limits. So the CBC was completely normal. His BMP, so basic electrolytes, were normal. His liver panel was normal, so that includes AST, ALT, bilirubin, alk phos, those were normal. And his TSH was also normal. His albumin was low at 2.8. His creatinine was 1.19, and his previous baseline was about 0.9. And then his total calcium on admission was 16.8. Some initial imaging that was done in the emergency department. They did a CT, chest, abdomen, and pelvis with contrast that showed no masses or any other evidence of malignancy. And his CT head, for the reasons that you guys stated, without contrast, showed no acute changes or evidence of acute intracranial bleed. So with those results back, Heather, what do you think are the next steps? What would you be wanting to do next? What other labs would you be ordering? What do you think would be the next steps for taking care of this patient and for diagnosing this patient?
Yeah, so I'm totally shooting for the hip, from the hip here, but with that high of a calcium, do you want to get an EKG at this point? Is that something you start worrying about?
Yeah, for sure. I think when in doubt, EKG is quick, fast, cheap, easy, simple.
Yeah. Did you get a glucose level for him?
I did, and I could pull it up in the chart if you'd like, but it was normal.
It was normal. Okay, because I was like thinking, like, wait, could this be like hyperglycemia or something? But yeah, I would do an EKG at this point. But
yeah, so John, on top of an EKG, what would be the next steps as far as labs that you would order? We're probably bringing this patient in at this point. I think that much is clear that he'll be admitted.
Yeah.
But immediate medications or labs, what would you be doing for this guy?
Sure. So the most concerning is the hypercalcemia. 16.8 is extremely high. And even with the correction for the low albumin, puts it over 17. There's that slight correction for every, I think, 1 below 4, you can add 0.8 to the calcium. So corrected, it's probably like 17.6 and change. So right now I'm thinking that he's probably got some sort of malignancy. Somebody just doesn't get dehydrated and gets a calcium of this high. The things that are related to calcium and calcium metabolism and control within the body are parathyroid hormone, vitamin D. I'd make sure we have like a mag and phos as well. So I'd be checking those or adding those on to the labs that they've already drawn. But I think the immediate concern is the 16.8, and the way that we approach and treat hypercalcemia is typically we start trying to excrete it, ways that we can with fluids and diuretics, and you can give certain like bisphosphonates. I think can be used in a kind of acute setting. And there's, trying to think, there's one other kind of specialized medication that I've used like once or twice for calcium that's high. It'll come to me, but certainly want to treat the hypercalcemia right away, and then start looking at reasons why the calcium's that high with additional lab work.
Absolutely. That was a wonderfully concise treatment of, first we've got to stabilize our patient for the reason that Heather mentioned. High calcium can definitely affect the heart. And so we want to be careful about making sure that our patient doesn't decompensate while we're sitting there trying to think of the diagnosis. One of the common misconceptions in med school. So right on the dot about correcting for albumin, I put on the takeaways there. The easy way is to just, for everyone that the albumin is off, change the calcium by 0.8 in the opposite direction. That's kind of the quick and easy. You can also get on MD Calc if you forget. You can just type that in Google. It'll do it for you real quick. So when we corrected our patients, it was 17.7, so it made it even worse. And then his ionized calcium was 2.26. So the ionized calcium actually tells you how much of the calcium is actually active in the blood, as opposed to the calcium that is bound to albumin. So that's kind of a way to kind of confirm that it's true hypercalcemia, is to check the ionized calcium. And then, so initial management of hypercalcemia. I've had it explained to me, the management is fluids, more fluids, and then you can do some bisphosphonates, and then maybe some calcitonin if it's still pretty bad. So there's some controversy about do you do fluids with a loop diuretic like furosemide. That's kind of been, from what I understand, pushed out of favor a little bit, just because you don't want to further concentrate the patient's blood with too much loop diuretic. So I've had different attendings do it differently, but that's something you can consider especially if they are a known heart failure patient.
Yeah, I'll say, yeah, they're usually hypovolemic, so definitely fluid resuscitate them first. And then if you're at the point where you're needing to push more fluids, but you're worried about volume overload, then you can try, potential diuresing with fluids. And it's not many situations where you're giving kind of free water and diuretics, but certainly if they're going to be hypovolemic, fluid resuscitate first. Don't give them Lasix right off the bat. But if you're running into hypervolemia, then you can add in the diuretics to increase free water.
Perfect. And would you start this guy? 2 questions. Would you do normal saline or lactated ringers? And then what rate would you start him out at?
Somebody like this, you could almost reach, and I don't know the literature on the exact, if there is a preferred fluid here. Sometimes, D5 is more of the free water, and as long as their other electrolytes are probably okay, sometimes you could start off with some D5. People use LR and normal saline. People go back and forth about that still. For the most part, I use LR. I would have to double check and see if there may be a little bit of calcium in LR. I can't remember. I'd have to double check. I don't know that, but would want to make sure I'm not giving them any calcium in LR. But I think D5 or like normal saline would probably be fine then.
Quick Google search tells me that there's 2.7 milliequivalents of calcium per liter of lactated ringers. So not a ton, but some.
Not a ton, but yeah.
Awesome. So our patient was started on normal saline at 200 mils per hour is what we started him out on. It was later decreased to 150 because it was found that he does have a history of CHF. That was not known to us beforehand. And so we started to see some fluid overload. If you had a patient where, you're wanting to pump them full of fluids to decrease the concentration of something toxic in their blood, but they've got heart failure, John, do you kind of have an approach as to how you would try and balance those 2 things?
Yeah, it's really, really tricky. Certainly knowing what their function is kind of helps guide. I mean, I guess, or makes me feel a little bit better if their EF's like 35-40 as opposed to like 10%. That makes me feel a little bit better about giving somebody fluids with 35-40. I'll take a quick look at their chest X-ray just to kind of see maybe where they're at from a heart failure standpoint already, or see where their BNP is. Sometimes if they're coming in dehydrated, it kind of gives you some leeway to kind of resuscitate them and then kind of back off. But just knowing kind of the recent EF is helpful, and then just looking for signs of volume overload. Peripheral edema, JVD, assessing JVD. If they're getting to the point where they're needing oxygen, that's probably you're giving too much fluid. But just kind of have to balance all those and accept the risks of the fluids and treating hypercalcemia with his heart failure.
Perfect. Thanks for the insight. That's really helpful. So our patient, like I said, received the IV fluids, and then we also gave him some zoledronic acid, which is a bisphosphonate. So he got 4 milligrams of that over 15 minutes. So that's kind of the guideline initial treatment for severe hypercalcemia. Although it's important to know that that doesn't work for about 2 to 4 days, depending on the patient. So that is not something that will acutely help your calcium, which is why you need to do the IV fluids. And then our endocrine colleagues also recommended some calcitonin for him as well. That tends to work a little faster in 12 to 24 hours, but it doesn't last as long. So that's what he received. He got 4 units of calcitonin. So given the current status, so we're treating him for the hypercalcemia, but hypercalcemia is not a true diagnosis. It's more of a sign of something else going on. So Heather, with that being said, what's kind of the top things on your mind right now as far as his hypercalcemia? What are you concerned about, and what would you order as far as a workup to try and figure out what's causing this?
This is not an original thought because John already said this, but concern of malignancy in him. So I like looking through our physical exam, like abdomen exam, unremarkable. So we're not thinking like some sort of abdomen mass. So it's like, where could a cancer be hiding that we would want to look for it? I'm not sure. Like what the first thing you do to like figure out exactly where something like that could be located. I mean, full body PET scan, but no one does that, right?
Oh, it's done. It's just, it takes a little bit of convincing.
Oh yeah, yeah.
All right, so John, so what's kind of on the front of your mind, and what would you do to try and figure out what's going on?
Sure. I'd be curious to know what the PTH came back as. If the PTH was appropriately suppressed, then you could check the PTH-related peptide to see if that's elevated, if there's some sort of exogenous production of PTH. If the PTH came back super elevated, then you could be thinking of like a pituitary adenoma or some sort of kind of PTH secreting or kind of tumor. So I would want to see what that lab looked like, but then might do like an ultrasound of the neck just to see if there's any abnormalities within that.
For sure, awesome. So I can answer some of those questions. So before I give you some numbers, I'm going to be a little more cryptic. So initial workup for hypercalcemia. First things to remember is that common things are common. So not particularly in this patient, but always checking the med list for any sort of medications that could cause hypercalcemia is a good first step while you're doing other workup as well. So the most common things for that would be like thiazides. Vitamin D toxicity is more common than you would think sometimes. Oftentimes we Americans like to think if some is good, then more is better. So patients can sometimes take a ton of vitamin D, not realizing that they can actually overdose on it. So that's something to maybe look into med list or ask the patient about. Like you all have mentioned expertly, cancer, especially with the calcium of like greater than 13, cancer has to be on number one on your list until proven otherwise. And that can happen from a couple different ways. It can be the cancer itself actually invading the bone or coming from the bone and eating it up itself, or it can be from the PTHRP, like John mentioned. That's more of a paraneoplastic syndrome that can cause some bony degradation. And then some other things, if the calcium is less than 13, and oftentimes if it's even milder, like less than 11, some other medical conditions are more common, including primary hyperparathyroidism. Some other things to look into would be any sort of granulomatous disease can cause hypercalcemia, and that happens because the macrophages actually will metabolize vitamin D to its active form. So you can kind of have some elevated 125 vitamin D, which we can also get on labs. And then something to never forget about that I have learned tried and true in the emergency department this month is the thyroid can do anything. So thyrotoxicosis is also a common cause. So it never hurts to get a TSH. So that all being said, so some of the information you guys asked for, his PTH was elevated at 108.6. So the normal range for that is 10 to 65. So his wasn't like crazy elevated, but definitely elevated, especially in the setting of hypercalcemia. His PTHRP was normal, which is something that I learned, that it is normal to actually have a little bit of that detectable in your blood, which I thought it should not be there at all, but it can be there and be normal. His serum vitamin D25 was 30.3, which is normal. His vitamin D125, which is the activated version, was undetectable. And we did an SPEP, which is a serum protein electrophoresis, that showed an acute phase response, but with no M spike. So with that extra information, Heather, does that kind of push your mind in any way?
What is an SPEP? Oh, is that,
Yes.
Okay, you know what I'm talking about.
The thing. Yeah, so an SPEP is going back to our our chemistry days back in undergrad, where they will just do a protein electrophoresis to separate out the different proteins in the blood to see if there's any like monoclonal. So we're looking for like a multiple myeloma or something like that. So his showed increased protein, but it was consistent with an inflammatory response and not a monoclonal response.
Okay. Okay. But that doesn't necessarily rule out all. Okay. I'm going to defer to the expert.
I don't know if I'm an expert, but so it's interesting that the PTH, 108, that's not, like you said, kind of crazy high. I mean, it is certainly inappropriately elevated. It should be suppressed due to the calcium. The serum vitamin D 125 was undetectable. That's a little interesting, and I'm not as familiar with some of the vitamin D metabolism, but I know that's the active form, and it's usually activated in the kidneys, and he's got normal renal function. So I'm not quite sure why that's undetectable, or if there's some feedback loop that suppresses that active form with this calcium being that high. That may be the case. I don't know the intricacies of the vitamin D metabolism, or I've forgotten, probably learned in med school at once, but would want to look more into that and just that pathway and see if I can explain it with what I'm seeing. Since his PTH is elevated, would like to actually look at the parathyroids and can start with an ultrasound of the neck, then go from there and see if you can find some sort of adenoma or something.
Awesome. I really appreciate that you are wanting to look into the parathyroid first with an ultrasound, which is a very benign imaging technique. I think with a calcium this high, we're always taught in med school malignancy until proven otherwise. And so the temptation would be to go down the path of doing all sorts of invasive testing or PET scanning or something like that, when we can do a simple ultrasound to rule out or further evaluate a pretty common cause, even if it's not super consistent with the level of his elevation in his calcium. So I'll give you some info on that. So we did they did a 4T, let me back up a little bit. First, they did an ultrasound. Like you said, they did an ultrasound of his neck and found 2 separate masses on ultrasound that were worthy of further investigation. There was one on the left and one on the right. So they proceeded to do a 4D CT scan of his neck, which found bilateral hyperenhancing nodules that were consistent on imaging with parathyroid adenomas. He underwent some necessary pre-op clearance. He had lots of heart issues that weren't fully addressed, so he had to do kind of an extensive pre-op workup. But eventually he was able to get a bilateral parathyroidectomy, and the pathology did show just hypercellular tissue without any evidence of malignancy. So after some post-op recovery, he was discharged back to his long-term care facility and has been followed up with endocrinology. This case was a little over a year ago, and I've been following this patient in the charts, and he's doing really well. He hasn't had any recurrence and still no evidence of cancer anywhere. So that being said, now that we have kind of the end diagnosis, John, is there anything looking back at this case that, oftentimes things are more clear in retrospect? Anything that kind of pops out to you as surprising or consistent or inconsistent with what ended up happening?
I think we were kind of, kept a good kind of broad range differential to begin with, but certainly I think we honed in on some of the, the calcium at the kind of prior hospitalization and these recurrent altered mental status, and I think did our due diligence with kind of ruling out infection and recurrent stroke. It's I don't know about the timing of when people these parathyroid adenomas developed, or what kind of his calcium, did at the last hospitalization, if it, recovered nicely and then was fine, and then I'm not quite sure, but and it all kind of fits. They didn't treat necessarily the root of the cause, or at 11.4, a lot of things can cause kind of elevations of that, but then when you see 16.8, you definitely know that there's something going on, and this is the primary driver.
Awesome, great reflections. Heather, what about you? Looking back on this case, looking kind of back at your own thought process, anything that sticks out to you, or anything that, specifically sticks out as learning points for you on this one?
Yeah, definitely. So just finishing my second rotation of third year, I know that I'm still like starting to think clinically. So my brain is just like this smorgasbord of like everything. So it's really trying to be like methodical and start, okay, like grouping things. Cause then, you spit out all these words, but you're like, wait, what did I say? How do I follow up with that? So just trying to be really intentional about how you're thinking about each patient and in a way that you do it the same every time.
Yeah, and I want to throw a quick plug for the Clinical Problem Solvers have some awesome diagnostic schema on their website. I'm on the emergency department right now, and I will routinely go to their website just to look at they have these beautiful graphics laying out to try and help you walk through a chief complaint and have an organized way to approach a patient. And eventually it's one of those things that you just, go through that mental thought process enough times, and soon it starts to become pattern, and it becomes something that you don't have to look up anymore. It just becomes kind of a second nature. So that's the MISS mnemonic that I mentioned earlier is one of those for me, that I just used it enough that eventually it's second nature. And so I'm able to run through, and it's super helpful for kind of, like you said, creating some organization to the chaos that kind of goes through your head at first, and making sure you don't miss anything. All right. Some other things I wanted to mention real quick, just some other more nuanced management or treatment options for hypercalcemia. Steroids are always an option. So if there's not really getting any answers, or the patient just continues to have super high uncontrolled calcium, steroids can help tame it down. That's a Band-Aid treatment, so it doesn't fix the cause, but it's an option that we can keep in our back pocket. Again, at this point, when you're going for more advanced treatment, you're definitely going to have your endocrine colleagues on board. This type of stuff is not something that you should feel the need to do by yourself. Definitely having colleagues is a plus, not a minus. Some other things to keep in mind is that if, we have a lot of patients with chronic kidney disease, and there is a phenomenon called calciphylaxis that can be very, very painful and very difficult for patients. But so sometimes just treating kidney disease, and that would be something to talk to our nephrology colleagues about, which I know John is working with them right now. So that being said, John, have you seen any calciphylaxis? Have you heard much about that? I haven't actually seen patients with it.
Yeah, I've seen it once or twice, and it's usually more of kind of an end stage kind of sequelae of renal disease in people who have typically been on dialysis for a long kind of period of time. And trying to remember some of the physiology behind it, but I know there's a lot of like calcium kind of almost deposits, and you start seeing kind of skin necrosis. And it is a extremely, I think, painful process. And I think there is I can't remember there's one medication that sometimes we use, to help treat it, but usually it is more of an end stage kind of sequelae of renal disease, and kind of on that spectrum of these calcium disorders, vitamin D disorders. There's different kind of like different stages of calcium disorders in people with chronic kidney disease and end-stage renal disease.
For sure. Definitely a rabbit hole that can be explored at another time. Thanks for that insight. Any other reflections before we go on to teaching points from Kelsey?
being that you guys are in med school and some of you have already had your surgery, like rotations, but I know that was always kind of a pimp question, was talking about the parathyroid and, you know, the half-life of the parathyroid hormone. And it's kind of interesting when they do the parathyroidectomy, they're measuring intraoperative parathyroid hormone levels to make sure that they're decreasing. I think the half-life's about 5 minutes. And so they'll kind of watch the parathyroid hormone level decrease during the procedure and kind of see where it settles out at, because you want to make sure that you don't take all of them and then you kind of swing the other way eventually. So it's always something I remembered from third year medical school, and always remember and keep in mind when patients that have parathyroidectomies.
For sure. They definitely did that on our patient. I remember reading the post-op report and seeing their measurements. I think they do it like at 5, 10, and 15 minutes post-excision to kind of like, I think they call it like a biochemical cure in the OR to prove before they close up the patient. So definitely some really cool procedures there. Heather, any final reflections?
I don't think so.
Awesome. Kelsey, ball's in your court if you want to run through some of the teaching points.
Yes, I did have a quick question first, though, that you might or might not know the answer to, but do you know how long you follow up, just like checking calciums on these patients to check for recurrence?
That's a good question. You hope you cure them with a parathyroidectomy, and certainly while they're in the hospital, going to get daily labs and then follow up closely outpatient. I think I've had 1 or 2 patients with kind of similar presentations that I've seen in clinic, and we follow their labs. I think initially afterwards it was almost seemed like every kind of 2 weeks, and as long as they were staying stable, then we kind of like spread out the labs to every couple months. And he had a low vitamin D and low vitamin 125 OH actually as well, so we were kind of ended up replacing those and following his labs every couple months.
Cool, thank you. Hello. Okay, so I'm going to go through kind of the highlights of the teaching points. So, if a patient has a history of stroke and they have new onset altered mental status, you can think of, do they have another stroke? Is there a complication of previous damage that they've had? Or is there some further decompensation of some existing structural damage? If calcium is greater than 12 or 14, that can be due to an underlying malignancy. And so that's kind of a good indicator, like, hey, look at their screenings. Are they updated on their screenings? A good mnemonic for a differential for altered mental status is MINTS, metabolic, infection, neurologic, toxins, or structural causes. And then the CT head is a good screening tool that can be used to look for essentially neurosurgical emergencies that are causing altered mental status. And so, for example, like a brain bleed or a midline shift. And then hypercalcemia symptoms, kind of the main categories I always talked about, the stones, bones, abdominal groans, and psychiatric overtones. And then EKG changes can happen if it's severe, so you see a shortened QT, and they can have polyuria, weight loss, dehydration, all of those sort of things that go with that. And then an important thing to look at, if calcium is abnormal, you should definitely correct for albumin, especially if the albumin is abnormal. So as a general rule, for every 1 that albumin changes, you're going to want to change the calcium by 0.8 in the opposite direction as a general rule of how to correct that. And then when you're doing the initial workup of hypercalcemia, ionized calcium, PTH, and vitamin D are all good starting points, good labs to order. And then for the treatment of hypercalcemia, first and most important thing you're going to want to do is IV fluids. D5 and NS are both good fluids to consider starting with. And the 2 big reasons you want to do that are, 1, just to dilute the hypercalcemia, and 2, because these patients are often hypovolemic, they're dehydrated volume down. And then after that, you can start bisphosphonates. They're a little bit slower acting. And so they can take like 2 to 4 days to work, like the patient in our case. And then you can also use calcitonin. That works a little bit faster, 12 to 24 hours, but it wears off sooner. And then you might or might not give loop diuretics that basically can help kind of help you lose free water, get rid of some calcium. But kind of questions of whether or not that's right to do. Some say yes, some say no. And then an important part of the workup for hypercalcemia is checking PTH. And if PTH is appropriately suppressed, you can check a PTH-RP looking for malignancy. So if there's like a paraneoplastic syndrome. And then if PTH is inappropriately high despite the hypercalcemia, it could be a pituitary adenoma or hypersecreting tumor causing the hypercalcemia. And then when a patient has hypercalcemia, it's essentially an underlying, it's kind of a result of something. It's not really a primary diagnosis. And so you want to look for what's causing the hypercalcemia. So some of the causes could be cancer, which cancer has two main ways that it can cause hypercalcemia, one being a paraneoplastic syndrome and the other one being bony destruction from actual invasion of the bone by the malignancy. And then medications such as thiazides and vitamin D toxicity can cause hypercalcemia. And then a big one is going to be hyperparathyroidism. So primary hyperparathyroidism could be a common one. And then granulomatous diseases, like sarcoidosis, and then thyrotoxicosis. Those can all be kind of underlying causes of the hypercalcemia.
Awesome, thanks, Kelsey. Two other things that I totally neglected to mention earlier, but late is better than never, so why not? Two of the things that we were considering in this patient, other causes of hypercalcemia, just to be aware of in the back of your mind. Sometimes when someone is just very sedentary and not able to move around a lot, they can get hypercalcemia just from bone breakdown and muscle breakdown. So that's always something to keep in mind. Normally it wouldn't be as elevated as our patient's calcium was, but something to keep in mind. And then another common one is milk alkali syndrome, which if you haven't heard of that, it's super fascinating. I would highly recommend doing a quick up-to-date search or other internet search to look at it. Very interesting physiology, very common in people who have uncontrolled GERD, who maybe be popping Tums all over the place all the time. Again, I will kind of let that be a little teaser for your own investigation. It's a very fun pathophysiology to look up. So just some other common things to keep in mind. But with that, this was a wonderful discussion. Thank you all so much. Thank you, Heather and John. You guys were awesome discussants. Careful sometimes when you're such a good discussant, you're earning yourself another ask to come back. So we might.
This was great. This was great. I really appreciate all that you guys are doing. This is really something special. Keep it up. Happy to come back whenever you need somebody. So definitely look forward to maybe a future invitation again.
Sounds great. Definitely will come. Heather, thanks for joining us.
Yes, I had a lot of fun. Didn't know what to expect, but I'm happy. You convinced me.
Perfect. I love it. All right, guys. Have a good night. Keep wearing those masks. We'll see you next time.